بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It is my great honor and pleasure today to have the legend of regenerative medicine in Arab and worldwide. It was my great honor to invite Dr. Shahzad Anwar to have a lecture today in this exceptional webinar for the Egyptian Society of Anesthesiology and Acute Care, and he is kindly support us by all means, and he will present a unique lecture today, as he is one of the scientists of regenerative medicine worldwide. Also, we have Dr. Khalil Gom'a and Dr. Abdel Majid Alwan, our great professors from Iraq, our beloved country. Also, we have Dr. Yasser Rida and Dr. Abir Sharif. Both are Egyptian, but they are working in Qatar and United Emirates. We have our dearest colleague, Yasser Al-Tayyib, our Sudanese colleague, and he's working in Qatar, and he is one of the great support and great achiever in our society. It is my pleasure today to introduce our great professor, Dr. Hazim Saleh, the Vice President of Manufia University. And of course, Dr. Hazim Saleh support our society by all means and by all his power. And really, he is a very supportive of every scientific program. And he has a great position in Canada and Europe before being here in Egypt to be the man number 2 in Manufia University. I really have no suitable words to thank him for his time and for joining us. Thank you, Dr. Hazim. Dr. Hazim will have a short speech for us today. He will celebrate the presence of the all great men of regenerative medicine in our world. Thank you for you all.
Okay, so assalamu alaikum jami'an. Nice to be invited in this very important workshop. I do apologize because I'm in a public area, so it was on a short notice. So if there is some sound in the background, please accept my apology for that. Dr. Safa, thank you for your excellent effort for organizing such an important event, especially with having Dr. Shahzad with us and all other colleagues, brilliant in their fields. Of course, in Manufia University, led by our colleague, Dr. Ahmed Al-Qasid, he has a medical background, strongly, of course, support all activities. Nonetheless, of course, the medical part is the priority. Indeed, my background, while is engineering, but we have all the respect to what the medical science is doing to our society. And of course, among the strongest areas in our university are the medical and the engineering sectors, which are proud of. So I do thank you again for organizing this conference or this short discussion, which I think is going to be repeated several times. Wish you all the luck in that. In our university, our belief is that our staff are our heroes and heroines. We cannot do anything without all of them. So we do support all our colleagues. We appreciate any effort that by priority is for mankind, and indeed it has an impact on our university and other universities. We are very proud of that. So I wish you a very successful discussion today. Thank you, Dr. Safa, for bringing all this expertise here. I would like to thank everyone by his name, but please apology from my side if I cannot do so for the time being. But I will be following what's happening later on, inshallah, briefed by Dr. Safa of the activities, and would be pleased even to receive you in person in Manufia if one day you plan to do so. So thank you, Dr. Safa, for having me. And since just I'm in a public area, I may not be able to continue a lot, but good luck for all.
Thank you, Dr. Hazim. Thank you for your effort and time, and thank you for your endless support. Shall we meet again? All of us will meet again in May in our society conference, inshallah, and it will be in Manufia bi'iznillah, inshallah.
Good luck for all, of course. Welcome, everybody. Okay. Thank you.
شكرا لحضرتك. شكرا لحضرتك. شكرا. دكتور ياسر اتفضل. اتفضل.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Really, you make my day today. And I'm very happy to be with a pioneer from all the Arabic and Islamic world. And to be in the same board, this is an honor to me. Today, our star is Dr. Shahzad Anwar. I will try to make it summary because when he sent me that his short CV, I was in biography, I was impressed. So I try to summarize because I don't need to take an. Our star for today is from the beloved Pakistan and the beautiful Lahore. Dr. Anwar is a specialist in spine, pain, and regenerative medicine. He was the first Pakistani doctor earned American Board of Regenerative Medicine and the fellow of American Board of Regenerative Medicine. Also, we have in the same board Dr. Khalil and Dr. Abdul Majid, the first Iraqi people, and I'm proud about that, who get earned the American Board of Regenerative Medicine. Dr. Anwar is extensively recognized national and international. First time to know him last year. I was invited for his conference, but I apologize at last moment because we have the same conference in Isaac in Egypt. And today we're joining the two conference to make it continue to each other. And Dr. Anwar credential have a master degree in pain medicine, diploma of pain medicine, Lahore University, Harvard University, and have a fellowship of pain medicine from Hungary, and have FIBB, Fellowship of Intervention Pain Practice, from WIB, World Institute of Pain, USA. Now he is the director of School of Pain and Regenerative Medicine at University of Lahore. Also, he is the founder and the current president of Pakistan Society of Intervention Pain Medicine. Dr. Anwar has penned the book and over 100 international published articles. He also involved extensively in education, and this is one of the educational session. In summary, Dr. Anwar is a respected figure in pain regenerative medicine. So without telling more about him, he will start here in our society and Egyptian Society for Anesthesia and Acute Care, the first presentation about the future about regenerative medicine, which will be a very big part in our practice soon. And the stage for you is Dr. Anwar.
Thank you so very much, Dr. Yasser, for the kind words and an elaborative introduction. My apologies, I had a virus infection when I came back from London, but it has improved a lot, and I hope I will be able to cope with the lecture. I would need to have admin to share my screen.
You can find down this share screen, a green arrow down, just to click on it and put your presentation. Open your presentation first.
Right. Can it be seen now?
Yes, we can see it, but use a screen view. Sorry.
Yeah. Is it visible now?
Yes, no.
So thank you again. Thank you, Isaac. Thank you, Professor Safar. Thank you, Dr. Hamadi. Thank you, Dr. Juma, everyone for your support and everything, and introducing me to this beautiful community of Egyptian and Arabic physicians. And I hope that we will be sharing and learning from each other. And the idea is to develop expertise not only in pain and regenerative, and also collaboration amongst all the Muslim world and countries. So let's lead in this way. That's my prayer to Almighty, that we can all unite and work towards the betterment of humanity, and especially the people who are suffering in our parts of the world. So the topic for today's talk is regenerative medicine for degenerative. Hello. So the talk is regenerative
Yes, we hear
medicine. Yes, but there is background noise. Can you mute everyone else? Or we can mute ourselves. Right, so regenerative medicine for degenerative spinal and peripheral pain. These are my disclosures. I'm owner and CEO of Iffat Anwar Medical Complex, a 120-bedded hospital in Lahore. I'm Director, School of Pain and Regenerative Medicine at the University of Lahore, Pakistan. And this School of Pain and Regenerative Medicine is first of its kind, which will be offering PGD certification courses, masters, fellowship programs, and even PhD and postdoctorate. This is first of its kind in the world in the specialties of pain and regenerative medicine. It's an independent degree awarding institute. Then I'm faculty and examiner for World Institute of Pain, faculty member of Pain School International, Budapest, Hungary, faculty member for International Academy for Endoscopic Spine Surgery, Istanbul. I'm serving president for Society for Interventional Pain Medicine and Society for Regenerative Medicine. There are no financial disclosures regarding this lecture or talk. So coming to the start of the lecture, chronic low back pain impacts society in a big way. Low back pain is the most common cause of job-related disability. We all know this. It impacts 29% of the population at any given time. Roughly 150 to 200 billion dollars are spent on healthcare management regarding back pain and other degenerative spinal conditions. 33 million people are disabled. This is approximately 10% of the American population. That is huge. And 102 million workdays are lost annually. And let to be make sure that this is not a very recent, it's 2014, 11, and roughly 10 years old data. And there is a lot more numbers added to this one. So we need to know what causes spinal pain. Usually it is thought that every degenerative condition can cause pain, but we should be sure that degenerative process is not painful without inflammatory process. So degeneration itself is not painful until and unless it is associated with secondary inflammation and inflammatory process. In spine, how does it happen? The first tissue in the body to start degeneration is the disc. We all know this. It starts degenerating in mid-20s and then degeneration accelerates with aging. Right? So what happens is with progressive degenerative disc disease leads to end plate erosions. This end plate erosions results in secretion of inflammatory markers that will lead to discogenic pain, and this will be most of the time axial back pain. Then with time, as the disc further degenerates, collapsed disc affect the posterior elements. What it does to posterior elements, that it causes lumbosacral and sacrococcygeal spondylosis, and this will ultimately lead to festogenic pain. And in addition to this, there are osteophytes along the facet joints that will further damage the sensory branches coming from the dorsal MI, and that will cause both rapid pain in the buttocks, thighs, and the axial back pain. Ultimately, if degeneration continues further, there will be instability. It can cause spondylolisthesis and instability of the spine. So all this, when there is facet arthrosis, degeneration, ligament laxity, and folding of the ligaments, this will lead to spinal stenosis, both in lateral recess, in the foramen, most importantly, in the spinal canal. The spinal canal will cause neurogenic claudication, and it will cause radicular pain and as well as back pain. So this is the summary, not just the degeneration, but the secondary inflammation and the other degenerative cascade. how it causes axial pain and the radicular pain. So lumbar multifidus muscle is a cause for chronic low back pain. We all are familiar with different causes of these back pain. We discussed degenerative disc disease, bulge, protrusions, facet arthropathy, spondylosis, stenosis, all those things. But this multifidus dystrophy, malfunction, dysfunction is one major cause in refractory. I don't know, somebody is playing with the blocks and all this, and it's blocking my screen. Please. Right. So lumbar multifidus is very important for.
I'm sorry, Dr. Shahzad, for these lines on your screen. Every time someone do this, the same mistake, I don't know why, and I'm so sorry for you.
No, it's all right, but lines are not important. Those big blocks, they just simply block the screen. My apologies.
I'm so sorry. I'm so sorry.
Right. So lumbar multifidus muscle is important for spinal stability and controlled motion. I've said controlled motion because it not only helps in stabilizing the spine, it also helps the overextension, stops the overextension rotation. So it limits the movement along with the help of the facet joints. So lumbar multifidus muscles are important for providing segmental stability as they function as dynamic stabilizers of lumbar spine. They reinforce lumbar lordosis during rotation and antagonize lumbar flexion, right? So when we move forward, they do extend to a limit, and so they stop the spine going into exaggerated flexion. And they definitely, when they go do contract, they help in the lumbar rotation or the extension on the backside. So low back pain is often associated with fat infiltration in lumbar multifidus muscle, and increasing fatty infiltration of lumbar multifidus may lead to lumbar dysfunction and pain. This is brief origin, this from the mammillary process and the slide part of the transverse process. Then it goes up and it terminates on the spinous process 2 to 3 levels above. So this is how all this, and below it is tied to the lateral part of the coccyx and the lower part as well. These are few of the studies. This is an old study from 2009, which mentions that low back pain, a highly prevalent problem in society, is caused by the lumbar multifidus dysfunction and fatty infiltration. Then another recent study, the correlation between, this was 2017. Correlation.
يقعد على الارض ليه؟ تقريبا.
Excuse me, Dr. Anwar. Please, dear colleagues, mute all microphones, please. Just let Dr. Anwar continue the lecture, please. All microphones put to mute, if you don't mind. Thank you. Continue, Dr. Anwar. Sorry for this.
Correlation between lumbar dysfunction and fat infiltration in lumbar multifidus muscles in patients with low back pain. Again, huge number of patients with good p-value. This study and many other studies, they definitely prove that lumbar multifidus dysfunction or fatty infiltration is associated with. These are few images from MRIs The first one, which shows normal, we can see there are only very few streaks of the fat, and most of the area is the muscle fibers. Then on the right side, we can say that this area has been replaced by muscle by the fat, and there are no more muscle fibers there. So then further and further, and then in sphere, you can see most of the fibers have been replaced by the fatty infiltration. This is the worst form of the in multifidus dysfunction. Then this is the grading. Grade 0 means normal, that is less than 10% of the fat is normal. This is called grade 0. 10 to 50% is fat grade 1. This can be easily reversed and with exercise and all this. And then grade 2. This is where we do interventions, we do medial branch blocks, we do RF rhizotomies or blocks or whatever. Patients do not respond for a long term. They come back with recurrent refractory pain. The reason is because of lots of fatty infiltration, multifidus does perform its function, and because of that, all that pathology I've discussed previously comes into account, and it will lead to both axial and radicular pain. So we have come up with a protocol which I will be sharing to treat the extreme multifidus dysfunction with regenerative modalities and neuromodulation to help these patients long term. These are these cytal images showing again this white replacement of the muscle fibers with the fat. So if we come to sources of pain, generally we discuss three sources of pain: discogenic, festogenic, vertebrogenic. But another important is myofascial. That includes both laxity of ligaments, dysfunction of multifidus muscles, and other paravertebral muscles. So if we come to the treatment for chronic low back pain, in all chronic back pain, the surgery has been considered as a gold standard. And this is a comparison between 2000 to 2009. If we talk of surgery for scoliosis and instability, which is justified one, because where there is more than grade 1 retrolisthesis or patient has instability and there is possibility of developing cardiac pain and water block, all those things, then surgery is justified, and that accounts only for 38% of the total spinal surgeries. The surgery for chronic back pain with stable back, that accounts for 62% of the total surgeries, almost 2 times more than where it is really indicated. So surgery rate has increased more than 2.5 times from 2000 to 2009. We can see anterior lumbar interbody fusion was 2.2 per 100,000. It increased to 2.6. P-value is again 0.008, more than 0.05. Then posterior lumbar interbody fusion or posterolateral fusion, 4.5 to 12.7, almost 3 times. And then posterior and anterior lumbar fusion, complete fusion from 0.8 to 2.5%, threefold increase. So this is, and still it's the same pattern which is going on. What surgery does to treat degenerative spine? What it does, the surgeries reduce pain, removing the pain generator. What is done? It's done either the laminectomy is done, hemilaminectomy done, or the disc decompression or discectomy is done. This eliminates pain by stopping motion and fixation. You can see all this hardware being put in the lumbosacral spine. It targets the symptoms of pain rather than its root cause, right? And so that is the reason after a few years, patient come up with pain, and unfortunately, nothing elaborative could be offered. In spite of this, different interventions have been developed which can be done. It does nothing to stop disc degeneration or induce disc regeneration. So that is the problem. When disc will continue to degenerate and it will keep on collapsing, And with the aging population, there is osteoporotic bone density is decreased. The screws which have been put through the pedicle, they all get loose, and there are loose. I mean, there is a big mess later on. So, but in addition to that, not only it helps in, it does not help in stopping degeneration or creating regeneration, rather it increases the degeneration at adjacent segments. So it increases adjacent segmental disease. This is a beautiful Cochrane review from 1999, old one, but still valid one. It concludes that there is no scientific evidence on the effectiveness of any form of surgical decompression or fusion, both, whether we do surgical decompression or fusion for degenerative lumbar spondylosis compared to natural history, placebo or conservative treatment. We all can see there is no point of doing any surgery only for chronic low back pain with a stable spine. Right? So in 1990s, where the treatment algorithm for spinal pain was diagnosis, then we had physical therapy, OTC, pain medications, then first year of pain therapies, non-steroidal, stents, physical, psychological therapies, nerve blocks, then second year was opioids, neurolysis, neurolytic blocks, and then thermal procedures like RF and all those. Then advanced pain therapies included neuromodulation, and drug pumps, surgical intervention, neuromodulation, all this. And if this all failed, the surgery was the option. But in 2020s, in acute on chronic or chronic pain, when patient presents to us, we start with epidural, facet blocks, radiofrequency, rhizotomy, sympathetic blocks, then and neurostimulators, both SCS and peripheral nerve stimulators, intradiscal biaculoplasty, intradiscal procedures like intradiscal ozone for small contained bulges, plasma coblation nucleoplasties. If this doesn't help, then we move to minimally invasive surgical options, vertiflex, endoscopic disc decompressions, sacroiliac joint fusion. And if all this does not help, then the option was extensive surgical option or all those fusion and all this. But now, fortunately, we have another option that is called the regenerative medicine therapies. That is what we will be discussing tonight, inshallah. So why do we opt for regenerative medicine? It has both short-term and long-term symptomatic, and it not only provides the symptomatic relief by reducing the pain and inflammation, it heals the injury, both joints, disc, annular defect, by creating a controlled cycle of inflammation, attracting all the mesenchymal stem cells, all those things. We will discuss this in later on. And the long-term goal, it addressed the root cause, change the course of the disease. It also addresses the root cause and changes the course of the disease. It stops or slows the progress of degeneration. It provides regeneration of the tissues. I'm sorry. So what is regenerative regenerative medicine? And NIH defines, National Institute of Health USA defines regenerative medicine as the process of creating living functional tissues to repair or replace tissue or organ function which is lost due to age, disease, damage, or congenital defects. So This is creating living functional tissues or harvesting them from your own body to repair or replace or regenerate organ or tissue damage which is caused due to aging, disease process, any traumatic damage, or congenital defects. This field holds the promise of regenerating damaged tissues and organs in the body by stimulating previously irreparable organs to heal themselves. I hope I've tried to be slow and simple to make it easy and digestible. So there are two main branches of regenerative medicine. We as physicians and clinicians are doing cell-based therapies, while our research scientists who work in lab, they are focusing on working on tissue engineering, 3D cloning, 3D printing, bioinformatics, all those things. So, but today we will be discussing different cell-based therapies, which include platelet-rich plasma, stem cell therapy, and the exosomes. So we'll be discussing this briefly, and we'll try to make it as digestible as possible. So what happens with aging, degeneration? That is natural. And what happens in after the middle age or in the advancing age, that wear and tear in the breakdown in the body, that increases and it outweighs the repair process. That is why we get degenerative spine, degenerative joints, muscle wasting. So everything that is because of increase in breakdown and decrease in the repair mechanisms. So basic regenerative principle, or the basic principle of all the regenerative medicine modalities, is to shift the balance from breakdown side to the repair side. So that is the way it affects. So what we are trying to achieve is slow down the breakdown and improve the repair mechanisms. So regenerative medicine is really a hot topic for research for last few years. There is dramatic rise in regenerative medicine references both on PRP and stem cell therapy in medical journals. Just during the 2022, over 14,000 references in PubMed, including nearly 250 systematic reviews and meta-analysis, and that is a huge number. If we search PubMed, you can find, just for regenerative medicine, you will find nearly 100,000 results. And if we search for stem cell therapy, we'll get more than 156,000. So that is a huge, huge number. So what options do we have for the regenerative treatment? So we have, I'm talking about the cell-based therapies, not talking about the tissue engineering or 3D printing or the bioinformatics. So regarding our physicians, we have both acellular therapies and the cellular therapies. The cellular therapies, the most commonly used one is, the most promising one is exosomes and the microvesicle-based treatments. Then we have alpha-2 macroglobulin, that is both we can have autologous or recombinant for the treatment of degenerative osteoarthritis. Then we have high-density collagen for disc regeneration. We have injections of recombinant growth factors. We also have intradiscal fibrin sealant for annular tears and annular wear and tear. Then coming to cellular therapies, which is the major topic for today, we have platelet-rich plasma. Then we have autologous stem cells. We are doing here all bone marrow concentrate derived, adipose derived stromal vascular fraction and mesenchymal stem cells, and peripheral blood derived very small embryonic like stem cells. Then We are not doing in Pakistan, it's not allowed, but some centers in the world are using allogenic stem cells, umbilical cord based or whatever. Then there are different laboratory expanded cells in the lab. And now what we are trying to do is we are combining all three, platelet-rich plasma, autologous stem cells, and the exosomes. And today we'll be discussing all these three. So coming to platelet-rich plasma. So PRP is the autologous blood. Autologous means we take the blood from the patient, process it, and then we re-inject the components we have derived. We'll be discussing what we harvest from the autologous blood. So platelet-rich plasma is blood plasma that has been enriched with platelets, that has greater concentration of platelets than the normal circulating blood. So as a concentrated source of autologous platelets, PRP contains and releases through degranulation several different growth factors and other cytokines that stimulate healing of both bone and soft tissues. So PRP is being used for hair improvement, cosmetics, musculoskeletal pain, and non-healing fractures. So this is a beautiful thing. But the key is we should know where to inject which sort of product. So this is when we do centrifugation, there are different methods. One of my colleagues asked me to elaborate whether do we need double spin, soft spin, hard spin. So I've been doing PRP now nearly for 20 plus years. It's since 2001, we starting doing PRPs. And at that time, we didn't have any soft spin centrifuges, or the only thing we were doing was centrifuging it at around 1800 to 2700 RPM, and then let it slow down. And then we used to aspirate this Buffy coat, which is the central 1%. So when we centrifuge, we get three parts. The lower part is the RBCs, that is almost 45%. And then about 1% is this dirty coat, like this is Buffy coat. This is where actually most of the platelets and the things we get. And then we have plasma, and this plasma has two parts. Be sure that we initially we used to waste everything else except from the Buffy coat. But now there have been different articles. If you can ask, I will share with everyone, or you can email me, that we don't need to waste even 0.1 ml of it. So what we do is, we take the Buffy coat and the adjacent plasma. So this is about 5 to 10% of the total volume separately. Then the upper part, which is the next closest to that part of plasma, is really, really rich in alpha-2 macroglobulin, A2M. Alpha-2 macroglobulin is the strongest protease inhibitor. And I'm sure we all know that what protease inhibitors do is, protease inhibitors are the major cause of cartilage degeneration. They inhibit the cell function of the cartilage. It produces less fluid or gel that decreases the bouncing effect, increases the friction, so it increases the degenerative cascade, and then the secondary inflammation, and then it can lead to pain and all those things. So this part, especially if I have to prepare the PRP only for the knee or shoulder or hip for intra-articular injection, I will never go to this Buffy point. I will insert my needle and stop half centimeter above. So please note this, when you have to inject PRP for any intra-articular injection, we don't need lots of platelets because platelets are come along with the leukocytes. And when we take Buffy-coat, we take lots of leukocytes, we take platelets, and then we also take some RBCs, right? So when we inject this reddish leukocyte-rich PRP in any joint cavity, it will have devastating effect. Patient will complain of lots of increase in pain and also increased joint destruction by the effect of leukocytes and RBCs. So we have to be very, very careful. If this one point all of us can take home from today's talk, that for any intra-articular injection, please stay half centimeter or 5 millimeter above the Buffy-coat. Then you can take 2 to 3 ml without any red or pink tinge to it. This will be leukocyte poor PRP with less number of platelets, less number of growth factor, leukocytes, but it will have lots of alpha 2 A to M molecules which have high density but lesser density than platelets. So they are suspended at this level, 0.5 centimeter or 5 millimeter above. So when you take from this level and then you can inject, that is what we need for cartilage regeneration, because alpha-2 microglobulin will inhibit protease inhibitors and the other factors will improve the regeneration. So this is one most important point for today's lecture. So this is again the same two types of PRPs. One is leukocyte rich. This we can inject anywhere except intra-articular. That means if we take the other way, when I have to inject for tendinitis, say tennis elbow, piriformis, or any muscle or ligament injury, what we do is we go down and from here, we just take half an ml of the plasma and then we re-inject it and it will mobilize all the Buffy-coat. Then we can aspirate it with the needle without taking lots of RBCs. If we don't put that half ml of plasma on this, then lots of RBCs come and they further can cause pro-inflammatory cascade, and patients will come up with that we have increased pain for 2 weeks or so. So to avoid that, even we can take RBC-free leukocyte-rich PRP. The protocol for that is take a longer needle and go just above the Buffy-coat, take half to 1 ml, and then re-inject into it. The Buffy-coat will mobilize and then you can aspirate it without aspirating lots of RBCs. And this can be injected into anywhere for skin, for melasma, I mean, anything outside the joints. But for joints, be sure that we inject leukocyte poor PRP, and that is rich in alpha-2 macroglobulin. I hope I've made it easy, I've made it simple and easy to digest. Then different growth factors which insulin has, insulin like growth factor 1, SDF1 alpha, it supports adhesion, migration of mesenchymal stem cells. This is very important that PRP secondarily activates mesenchymal stem cells, which is the actual workhorse of the body for the regenerative cascade. And for that, SDF1 alpha is the most important. Then we have bone morphogenic proteins, It's for osteogenic derived cells, so it helps in bone growth. We can use it for non-healing fractures and all those things. Then GDF5, fibroblast, mesenchymal cell expansion. Then we have PDGF, platelet growth factors, transforming growth factor beta 1, which stimulates angiogenesis. For any sort of healing, we need to have increased blood flow. So this TGF beta 1 helps in angiogenesis, and that definitely helps. If we have any consultants from eye, we are developing a protocol where we exclude this factor from PRP to inject intra-articular for diabetes-related problems. And then we have vascular VEGF, vascular endothelial growth factor, then FGF, fibroblast growth factor. It mediates growth of skeletal muscle, cell differentiation in repair. So all MSK disorders, and like we said, that multifidus dysfunction. So it can be PRP is just like Holy Grail, as the Christians say, right? So then we have epidermal growth factor for skin problems. So it contains lots of, I've mentioned only 8 or 9, but there are more than 22, and there are more, but these were the most important. So important is the efficacy of PRP or platelet product. It depends on the concentration and the composition. So two things are important. We have discussed the composition, leukocyte rich. It contains platelets, leukocytes, the Buffy-coat, few RBCs, and all the rest. Then this is for all extra-articular, cosmetic, MSK, all other indications. And then we have leukocyte poor PRP that contains lots of alpha-2 macroglobulin for intra-articular, for degenerative osteoarthritis. In addition to that, the concentration is important. Optimal concentration for angiogenesis, which is the key for increasing blood flow, increasing nutrition, increased number of cell migration, all those is minimum 1.5 up to 3 million platelets per microliter. So make sure off and on when you get a PRP, a sample, you take it and then send it to the lab in-house or out-house to just randomly check that your concentration is between 1.5 to 3 million platelets per microliter. Inhibition was demonstrated at a platelet concentration of 5 million per microliter or greater, but fortunately no point of care PRP which is available in the market, or even we do manual, we can't reach. So we should not be worried about the higher concentration. We should have around 1.5 to 3 million. So that is where we should be. So no effect if platelet concentrations were below 500 into 103 per microliter. It supports proliferation no better than platelet poor plasma. I mean, that again, you see it's 2009-10. At that time, we did not have the evidence that what platelet poor plasma and alpha-2 macroglobulin can do, but still this is the accepted consensus that it should be over 1.2 minimum million for a better outcomes if we need to have platelet-rich, leukocyte-rich PRP. That is for ligament tissues, all those things, skin issues. But if we treat intra-articular, then this concentration is not important. Then alpha-2 macroglobulin is more important. And then there is again a study from Journal of Sports Medicine, and this was published in 2014. What does it prove? It proved that RBC-free, leukocyte-poor PRP should be used for intra-articular injections. Why? Fibroblasts like synoviocytes compose 80% of the synovium. Synovium produces cytokines and matrix metalloproteinases that mediate cartilage metabolism or cartilage damage. The effects of leukocyte-rich PRP was compared on human fibroblast-like synoviocytes, right? And it proved that leukocyte-rich destroyed the synoviocytes, increased the damage, while the leukocyte poor, that improved the health of synoviocytes. So leukocyte poor should be used, not the leukocyte rich with RBC should never be used. Right, so a bit about platelet poor plasma. We should not discard it. If we are doing intra-articular injection, there is no point in giving 3 to 4 ml of periarticular injection. I hope, right? Periarticular mean we can give in the superior compartment, just in the where the quads come, then we can give on the sides of the joint. So that will help. That has certain what we say structural proteins, scaffolding proteins, and it will definitely help some positive regenerative effect. Then A2M we already have discussed in detail, and this is a good source of alpha-2 macroglobulin. So it should be given intra-articular, and there are kits available to separate alpha-2 macroglobulin, but the cost is around 750 to 1,000 US dollars. Does not give any benefit. But again, the point is, if your needle is just 0.5 millimeter above the Buffy code and you take 2 to 3 ml, you don't need to spend this much of money just to separate ATM. That will serve the purpose, and we can give 3 to 4 shots of A2M rich platelet rich leukocyte poor PRP in the joint 4 weeks apart or 6 weeks apart, with or without Synvisc. That is a separate debate that we can discuss at any other time. Then this is the evidence, and there is, we can see for OA&E both level 1, level 2, trochanteric bursitis both level 1, level 2, rotator cuff tear level 1, level 2, lateral epicondylitis, patellar tendon, plantar fasciitis. So all these have level 1, level 2 evidence. For disc annular tears, we have few papers with level 1 evidence, but still majority of the level is level 2. Again, a study with beautiful outcomes. 16 patients with degenerative disc disease. 9 patients have both disc arthrosis and foraminal stenosis. They were injected 3 months at 3-month interval, follow-up at 3 months, 6 months, 12 months, and 2 years. Leukocyte-rich PRP was given 1 cc intradiscal and peridiscally when we come out of the disc, around the facet and in the paravertebral muscle. And you can see beautiful outcomes. That patient satisfaction means reduction in pain and improvement in function was 90% at 24 months, and pain relief was 2 to 4 points less, right? Though there was no improvement in height, no change in hyperintensity or modic type changes, but again, back pain is not a mechanical, it's again chemical and all those things. So beautiful outcomes, and a good study. Another study, observational series of 5 cases, 2 cervical, 3 lumbar, 3 PRP injections, intra and periarticular of facet joints, follow-up 6 and 12 months, 60 to 70% pain relief, improved range of motion and reduced medication, and most importantly, reduction in degenerative cascade. So the most important part of regenerative therapies is not only the symptomatic treatment, also the root cause. We are not only addressing the pain and stiffness and decrease in function, we are also addressing the root cause, and regenerative cascade is being triggered. Then this is the important, there are very few literature we will find on this, that as I discussed earlier, that multifidus is one major component, multifidus dysfunction, for refractory low back pain. Trust me, we used to treat patients with RF rhizotomies of sensory branches, medial branch blocks, and even DRG, all those things. But still, patient used to come back after 6 months or less than 1 year with complaining of refractory axial pain, though radicular symptoms were. So in those patients, what when we went through literature, we find out that when we target multifidus muscle, this is a beautiful study called the Reactivate study. This was done, a huge big study started in 2020, published in 2021, then another one follow-up 2023. So this is long-term outcomes of restorative neurostimulation in patients with refractory chronic low back pain secondary to multifidus dysfunction. This is 2-year results of the Reactivate B pivotal trial. This is a stimulator. I can show some later on with right. So what they did in this trial was they used electrodes like they use in spinal cord stimulator or the peripheral nerve stimulator, and placed them in the multifidus belly along the lateral border of the superior articulate pillar at L2 and L3. Say this is the superior articulate pillar, this is the transverse pillar. They just a bit lateral to, they inserted the electrode, gave the stimulation, and then they did the permanent. And what the patients did was they gave the stimulation themselves 30 minutes daily. And within few months, their intense pain intensity, all those things improved. So this was a landmark study, and you can see big number, 56, pain reduction more than 50%, 71%. So beautiful outcomes. But the point with this Reactivate study and using those what we call it electrodes is it costs around 25 to 30,000 US dollars, which is practically impossible for countries like we come from with huge populations and less economic resources. In my part of the world, nobody will invest 25 to 30,000 dollars for a back pain. Same is true for Egypt and other developing countries like us. So we have come up with a protocol, and you all can adopt it, and we can publish multi-center studies adopting this trial. This is very simple and very easily doable. You can have screenshots of this, or you can, I think this presentation will be available. What we do is we perform pulsed RF neuromodulation of multifidus muscle at L2 and L3 level bilaterally. So L2 bilateral, L3 bilateral, and 6 minutes each level. So we put 2 electrodes at L2, and then we put 2 electrodes at L3. So 6 plus 6 minutes, and you can use 1 electrode. You can do for 24 minutes. It take about, right? And then before taking out the cannula, we inject 2 ml of leukocyte-rich PRP at each level. So first 6 minutes of pulsed RF neuromodulation at L2, L3 bilaterally. Then we inject 2 ml of leukocyte-rich PRP at each level, and we perform 3 sessions. Minimum gap is 4 weeks and maximum of 6 weeks. So this is according to how far the patient is coming from. If they can come at 4 weeks, minimum is 4 weeks, maximum is 6 weeks. And we'll be publishing our data of more than 100 patients by the end of 2024 with MRI and everything, and with comparable or even better outcomes we had. And for this, you can compare the cost of few $100s to $25,000 plus. So this dysfunction of multi-feeders can be addressed very comfortably using pulsed RF neuromodulation, and the position of the cannula is slightly lateral. When we perform the RF rhizotomies, our angle come like this, and we are right at the capsule of the joint. So we give a bigger line. Here we are slightly lateral, and we land on the transverse process and just turn the tip and just move forward to the tip. Then we should get multi-feeder stimulation at 0.3 hertz, 0.3, and sensory about sensory 0.2 to 0.3 and motor 0.5 to 0.7. If we get this, we will get beautiful outcome. If you are more lateral or more medial, we can readjust. So we should get sensory stimulation at 0.2 to 0.3 hertz and motor at 0.5 to 0.7. So perform neuromodulation 6 minutes at each level, and then you can inject leukocyte-rich PRP at each level, 2 ml or even more, right? 3 sessions performed, and then definitely along with it, ask the patient not to sit for prolonged. Whenever I treat any back pain patient, I always ask them to do one thing: avoid prolonged sittings, because with modern habits we are sitting for hours in our office, driving. So this need to be avoided for us as well, because when we are sitting continuously, muscles, they get loaded, ligaments, everything we all know. So ask your patient to avoid prolonged sitting. And also one more thing, the stretch of Ruku, right? That is the best exercise. We can ask them to improve blood flow and all those things. Now the next segment is stem cells. I hope I'm not boring all of you. So stem cells are primitive, undifferentiated cells with the ability to divide potentially for indefinite periods and to give new stem cells, or to differentiate, giving rise to specialized cells, right? So stem cells, generally saying, have 3 properties. One is they are undifferentiated or unspecialized cells. They can divide and renew themselves, and sometimes after very long periods of inactivity. So they go into latency, but they keep their potential to divide and give rise to more number of cells. And third most important is, under certain physiological, pathological, or experimental conditions, they can give rise to specialized cells. That is why we use them to regenerate cartilage, to regenerate skin, to regenerate damaged organs, all those things. So they are unspecialized cells or undifferentiated cells. They can divide and renew themselves even after years of latency. And then under certain physiological, pathological, or experimental conditions, they can give rise to specialized cells. So this is again the same thing, picture depicting the same thing. And the specialized cell is that the stem cell go through atypical or asymmetrical cell division, in which it produces one daughter cell, and it produces a free lipid, not the cell. It produces a free lipid which joins with the precursor or a free cell to produce a specialized cell of that specific lineage. There are different types: embryonic stem cells, induced pluripotent stem cells, umbilical cord derived stem cells, adult stem cells. We are concerned with the adult stem cells, and that is what we are using. They are of three types. The most commonly used word over are bone marrow aspirate derived cells, then adipose derived stromal vascular fraction and mesenchymal stem cells, peripheral blood derived VSCL stem cells. So what are the properties? Self-renewal and potency, lineage, multi-drug resistance, plasticity, differentiation, all those things. So now a little bit about the bone marrow concentrate derived stem cells. They are mainly hematopoietic stem cells, 1 per 10 to 15,000 marrow cells, mesenchymal stem cells, 1 per 250 marrow cells. So that is one reason now we are using more adipose derived stromal vascular fraction, because that contains more mesenchymal stem cells and less hematopoietic stem cells. So it also contains adult and precursors of T and B cells, white cells. It contains concentrated platelets with all the growth factors. It contains scaffolding proteins, including fibrinogen, fibronectin, again alpha-2 macroglobulin, important. That is why it is being so commonly used for ONE, anti-inflammatory cytokines, and IL-1, beta 6 and 8, BMP2 and BMP7. And so how it functions? Hematopoietic stem cell give rise to all other types of stem cells. You can see mesenchymal stem cells can differentiate into fibroblasts, osteoblasts, osteocytes, adipocytes, and chondrocytes. So that is one reason we are using them in degenerative and MSK conditions. What hematopoietic stem cells do? They upregulate cytokine release and stimulate mesenchymal stem cells to promote, regenerate, plus the diseased or the local cells which were weak, they also stimulate the function of those cells. So hematopoietic stem cells are important. Cytokine, they release the cytokines and stimulate stem cells to promote regeneration. The use of BMAC is considered minimal. This is not important for us. BMAC contains a mixed population, and so it is believed to enhance the performance of mesenchymal stem cells. Now, briefly about the adipose-derived stem cells. So, just like mini lipo is done, in adults, it's done periumbilical fat that contains more niche and has more cells which we require. Then this adipose is washed, treated with antibiotic. Then it is treated with collagenase 1 for enzymatic digestion. And once that is done, then we do centrifugation. And after the centrifugation, this lower part, this is the SVF. This contains lots of things. And this small particle in the duct, all rest is not used, that is wasted. So liposuction under local anesthesia or sedation, adipose tissue is derived, then collagenase, saline, incubate, centrifuge, washing, and again, so we get this clot or this thing, that is where all those population is there. So what stromal vascular fraction contains is, it contains mesenchymal progenitor and stem cells, both. It contains pre-adipocytes, it contains endothelial cells, pericytes, T cells, M2 macrophages, growth factors, some hematopoietic stem cells. So beautiful cocktail of different cells. Then another cell type we are using is peripheral blood derived. This is very small embryonic life. Please, dear host, let me know if we are getting late, so I will make it quick. Dr. Yasser, Dr. Safa.
No,
So
we have plenty of time, Dr. Shahzad.
okay, thank you.
Yes.
Thank you. So population of very small embryonic-like stem cell, it represents a population of extremely small non-hematopoietic pluripotent cells in the circulating blood, right? So they are non-hematopoietic cells in very, very few quantity, but they are present, and because they are negative for hematopoietic lineage markers, and they express SCA1 in mice and CD133 in humans. That makes it that they are non-hematopoietic. Their embryonic-like characteristics include the expression of markers of pluripotency, the ability to give rise to cellular derivatives of all three germ layers, so they are pluripotent. The other two cells we talked of were multipotent. Multipotent cells are those which become from a specific lineage and related with that lineage, and under specific circumstances, they can undergo plasticity and can give rise to cells from other germ layers, but usually not. So these cells, these peripheral blood-derived stem cells, they are more primitive. They are more strong. They are as strong as induced pluripotent stem cells. That was the work was done in 2006 by Yamanaka and all those four Yamanaka factors. So they are equally effective, and still they can be autologous. And the studies have proven that after tissue injury, including acute myocardial infarction, bone marrow derived VSCLs, very small embryonic like stem cells, are mobilized from marrow to the peripheral blood, and they home to the damaged organ. So this is the proposed hypothesis that primordial germ cells, which are responsible for producing oogonia, spermatogonia, gametes, they produce VSEL, very small embryonic-like cell, which produces mesenchymal stem cell. It produces hematopoietic stem cell. It produces this endothelial progenitor cells and tissue-specific stem cells. And this HSCs and endothelial progenitor cells are produced by a intermediary hemangioblast. So this is how it can produce multiple cells, more strong. It has more capacity as compared with the pluripotent. So the procedure, as this is not being done in very commonly, I've just tried, will give a brief description, because this is the easiest procedure to perform and get better quality cells. So generally their quantity is very, very low. In bone marrow, it's 1.1 to 1.5%. In peripheral blood, it's 0.06%, 0.06. So with this, it's virtually impossible to harvest from peripheral blood. So for that, what we do is we inject filgrastim. This is a granulocyte colonist GCF, colony stimulating factor, which is routinely used after chemotherapy, radiation in patients. So this one injection, 1 ml containing 300 microgram, is injected subcutaneously like insulin for 4 consecutive days, right? And in certain patients, it may cause feverish feeling, and so we can give acetaminophen are prescribed, no NSAIDs are given. And then you can see after giving 4 injections, the concentration from 0.06% goes up to nearly 26 to 30, right? So that is where we ask the patient to come on the 5th day, and then we perform the procedure. Patient perform on the 5th day. They are advised to take lots of fluid, juices. When they reach, IV line is secured with an 18-gauge needle. We give prophylactic antibiotic, and then the kit which comes for harvesting of that is a specific kit. I will show you in the next slide. And that contains a 16 gauge cannula. It's the same cannula which is attached with the blood bag. So it's just as simple as we inject a blood taking cannula with a blood bag, just like that, right? So this is the component we use. This is Hamnetics multi-component system, MCS plus, right? And this is the kit. It contains different bags for different products. Then on the side, we get Buffy coat and our product. And this is the whole procedure. Patient is awake. And then in addition to this isolating this multi-component kit, we also inject ACDA, right? So ACDA is also attached. So what it does is this machine takes about 200 to 250 ml of blood. It centrifuges it in the Latham bowl. This is the Latham bowl, and it centrifuges it, and different layers are separated. The mononuclear cells or peripheral blood-derived VSL, they come in the layer of the white cells. So this is where they will find them, right? And then we have a separate Buffy coat, and we have, right? So it usually take about 2 to 3 hours. It takes about 250, 200 ml blood, process it, separates different components. We get Buffy coat separately. We get 120 to 150 ml of the product containing mononuclear or peripheral blood-derived stem cells. So with all the procedures in that, and patient is talking, and you can see, can eat, and all those things. It's very simple. No need of anesthesia, no sedation, nothing, anything, right? So there is another study showing that human very small embryonic-like stem cells are able to generate human bone tissue in mouse model. In this study, they injected human peripheral blood-derived cells in a mouse, and it generated bone, right? So finally, just few slides regarding exosomes. Exosomes are the current and the future direction. And being a cellular product, they does not fall in the category of stem cells or mesenchymal stem cells. So there are few legislation, and it is easy. They can be injected, they can be, and all those bylaws which are related with the autologous or allogenic stem cell, they are not concerned with exosomes because they are acellular, very small particles. They are usually 30 to 200 nanometers in diameters, and they are released in high quantities from rapidly growing cells, including stem cells, B and T cells, and even cancer cells. So exosomes contain an array of membrane-associated proteins, lipids, nucleic acids, and glycoconjugates, and are believed to facilitate intercellular communication through the paracrine effect, right? So they are important in intercellular communication that will ultimately lead to regeneration and all the excretion of those things, and that will ultimately lead to healing and regeneration, right? So exosomes, small vesicles, are produced by the cells, are vital in cell-to-cell communications. They carrying proteins and RNA from their cell of origin. So it is important we should be knowing the exosome product from which they are derived. Our team is developing exosomes from umbilical cord, again the strongest source, and then from peripheral blood as well, adipose-derived BMAC. So we are having all these cells, and even the patient who are very aged and with all those diseases, we can use umbilical cord derived, and being non-cellular, they don't have any all those complication of using the whole cell. So there is no cross-infection, no rejection, tissue reaction, all those things. So this is safe and it is cost effective. The applications of exosome therapy includes from, they can be used for drug delivery, regenerative medicine, immunotherapy, disease diagnosis, gene therapy, and still, though many of these are in experimental condition, but drug delivery is being done, regenerative medicine, we as regenerative medicine physicians are using it for, I'm sorry, for regenerative and pain management. And also exosomes may also be used by stem cell to detect their environment and repair damaged tissue. So yeah, so these are the different uses: drug delivery, regenerative medicine, including chronic low back pain or other degenerative diseases, immunotherapy. It can be used to detect biomarkers for disease diagnosis, gene therapy, all those. So huge, huge uses of stem cells, exosomes. I'm done with the theory part. Now I will be sharing few pictures of the patients what we have treated in our center. So this is one patient. This patient presented to us with non-healing fracture of C7 spinous process. You can see here in the red circle, right? And it was 9 months after the fracture, and everything was done in stable, immobilization, all those medications and everything. And then what we did was we injected both intravenously and locally PRP along with peripheral blood-derived stem cells. And you can see just after 4 months, both in coronal and sagittal sections, that this is the fracture and this is the same patient 4 months after post-VSCL treatment. And this patient again on sagittal, and you can see the complete healing of that. So beautiful outcome in bone regeneration, which did not heal for 9 months. Then another patient of mine, a middle-aged lady with huge disc protrusion, and she was developing potential cauda equina, but they absolutely refused. So what we did was we did first intradiscal plasma coblation nucleoplasty to remove the, to decrease the pressure on cauda equina. And after 1 month following plasma coblation nucleoplasty, we injected intradiscal and peridiscal PRP both at L4 and L5 level. You can see 11 months after the PRP and stem cell injection, the disc hydration has increased in both discs. You can compare. This is more grayish with annular tear and all this. This is no annular tear, lots of hydration in the nucleus. This also has increased. Though we can't say the height has increased, but we can say the hydration has increased and patient is still symptom free. And now it's been more than 4 years. So another patient of ours with knee osteoarthritis, and in the same patient X-ray and the same patient MRI, you can see there is no cartilage layer here. It's all inflammatory fluid. Then same patient, you can see on X-ray, no fluid. Here there is slight improvement in the space, that is because of the cartilage regeneration. And this you can see on the MRI that this is the cartilage regeneration and there is no inflammatory fluid, just the synovial fluid. And here you can compare it on the X-ray. So 6 months after, and this kept on improving, keeps on improving for up to 3 years. And if patient has a healthier lifestyle. Then another patient, you can see that nothing around all these inflammatory changes. And then post 3 years. This is 3 years follow-up, and there is still lots of this cartilage and everything. So content this shows in relation to blue signal. This means that there's lots of cartilage and all those things. So this is a miracle patient of ours, a young, fresh graduate dentist. Diagnosed with rheumatoid arthritis, and you can see the right hip. She also had involvement of other joints, but that was the worst joint. So the treatment protocol we did, to start with, we did intra-articular PRP, leukocyte poor, and we did PRP injection on some acupuncture points which have proven efficacy for immunomodulation. And then we did one session of peripheral blood-derived VSCL, both intra-articular and IV. And this was the first procedure. You can see intra-articular contrast, and then we injected PRP. This is after the third session. You can see the improvement in the joint space and all those things. And then this was the final stage. You can see all those, the joint space has come back, and the contours are regular. And 1 year after marriage, this young lady gave birth to a beautiful little girl. She was off all her disease-modifying drugs, thanks to Allah Almighty. Then another case of degenerative hip arthritis, you can see. So we did intra-articular and also intraosseous injections of PRP and PBD. So you can see the difference in the improvement. So here another patient. Here you can see the decreased joint space, and this is where we injected in adipose derived and leukocyte poor PRP, both intraosseous, and that is in the bone around the joint, and in intra-articular as well. And you can see the increased joint space and much better contour of the femoral head. This is how we do periosseous injections in the just around the acetabulum, and also in the head of the femur and the neck of the femur. So in addition to this, we are also working with our colleagues from other departments like neurodevelopmental, pediatrics, pediatric neurologists. This is our wonderful work. You can see a CP child, flaccid CP, improvements in 3 months' time, and the same child is perfectly fine, going to school, no neurological deficit, except a bit of hearing. All rest are fine, and now he's working for some IT company. Another young girl with severe spasticity, just 3 months down the road, lots of improvement. Another patient with, you can compare both sides, very weak left side can't, and the same child is walking in 8 or 12 weeks time, putting weight on the left side. So, and this patient was with cortical blindness. Again, we did PRP and stem cell on acupuncture and IV, vision restored, alhamdulillah. Another child with corticovisual blindness, that also improved. So for eye diseases, we are working with vitreoretinal surgeons and our Society for Ophthalmology, OSP, Pakistan. And this is one very interesting case. There is a non-healing trophic ulcer. You can say no shine. It was only finger counting, nothing else. Just 6 weeks after, we just only prepared the drops from umbilical cord derived exosome, and she just put 2 drops per day in her eye, and you see all the things improved, and she has come to 6/24 from finger counting. This is another Stephen Johnson, very notorious. It emulsifies the eye. An old lady pre-treatment, you can see, and you can see 6 weeks post-treatment, both eyes, huge benefits. And then another very notorious disease, that is retrocystis, something like it. Not a, there the retinal layer, they get detached and all this, and just by giving drops you can see the improvement. And here after 9 weeks, lots of improvement and vision restoration. And this all is being presented in eye conferences and all this. The bottom line is regenerative medicine works. It is more effective, it is less costly, it is less invasive than surgery for degenerative spinal pain without adjacent segmental disease, right? Stem cell augmentation, both allogenic or autologous. In our part of the world, it's only autologous. For disc degeneration, it improves degenerative spinal pain, improves function, significant improvement with durable treatments for years to come. It is superior to sham and conservative care, excellent safety profile. Stem cell augmentation is a viable and cost-effective short and long-term alternative to non-surgical management or surgery in management of stable degenerative spinal pain patients. So the way forward is we need to learn from others, our mentors, our teachers, our colleagues, and from all our own mistakes and experience. We need to integrate all possible modalities with good and promising evidence for treating different diseases. As a Muslim, I firmly believe that there is no disease for which Allah Almighty has not provided the cure. We simply have to discover it. Before finishing, I would like to invite all of you to join us for one of the, I would not say myself, but this is what our faculty and colleagues say, one of the very best congresses in the world on pain and regenerative medicine. We have theme both simultaneously running on chronic pain, interventional pain, and regenerative medicine. You can see we have best of the best faculty from all over the world, and also students of pain and regenerative medicine like me from Pakistan and others. Thank you so very much. Thank you. Thank you for bearing me.
Thank you, Dr. Shahzad, for this distinguished lecture, and it was fascinating one. Thank you for your endless effort to represent such a huge, voluminous lecture. Really, every second in this lecture, we are amused by this marvelous experience, and I have no special word to express my feeling toward you. Thank you, Dr. Shahzad, and I left the floor for my great moderators today.
Thank you.
Thank you, Dr. Shahzad. Before I leave the stage for my colleague Yasser, just I have an just not a comment, it's just like a question. The first question for me, I noticed used in last few cases you discussed some other modalities, because I think regenerative medicine will not abolish the other modalities. It can help the other modalities. What's your opinion about that?
Definitely. I mean, it's just the chronic where there is degeneration predominates the inflammation. That is where regenerative medicine should be used as a rule of thumb. But in younger patients, where is not much of the degeneration, it's just most of the inflammation and other things, then definitely other interventional techniques or other modalities are superior to regenerative medicine. So that is where we have to create a balance both between the but as pain physicians, we all know that the people who come to us, they already are suffering for years. So there to do another just an intervention and send them home and wait for them when they come back, it's always better to combine intervention with the regenerative medicine, like the one slide I shared of a huge bulging protrusion with impeding chorda vena, then we first did the plasma coagulation nucleoplasty. We treated the symptoms, we reduced the pressure on chorda vena. Then we went for regenerative after 4 weeks. So that is how it should be. So a balance between both interventional, conservative modalities and the regenerative modalities.
As a second thing, sorry, Yasin, for that, because this is a very important just for me, especially in my country, Egypt. There is a very thin, it's like a difference between what I see between use and the optimal use and the abuse. Because what I'm scared about, some people come to listen our presentation and don't have experience and don't everything can be treated by regenerative medicine. So, and this will lead to abuse. What's your opinion to guide the young physician about the regenerative medicine?
Yes. Not only for regenerative medicine, for any modality, if simply prescribing a painkiller or advising some bed rest, the rule of thumb is if you can't prescribe any medicine to your own mother, if you can't perform any block on your own mother, if you can't perform any regenerative modality on your own mother or daughter, never ever perform on anyone else's mother. So that is the gold standard. So if we take this in account, which we all are, we can escape from each other, from the patient, but no one can escape from Allah Almighty. He is Rahman and Rahim, but he's also Qahar and Jabbar. So keeping that in mind, so it is, the only thing is, that was the reason I focused so much on the different types of PRP, how to collect them and where to inject them, was that people are doing PRP without knowing where to inject which product. They have no clue which is leukocyte rich, which is leukocyte poor, which is PPP, what is alpha-2 macroglobulin. So this is my discretion, your discretion, Professor Yasser or anyone, that don't do anything which you can't do on your own mother. That is my take on it.
Thank you very much. I enjoy a lot and I learn a lot and I'm done. So thank you very much. I'm not sharing anything here. Thank you, Asif. Can I start?
Dr. Shahzad, first of all, I want to thank you so much for the great and comprehensive lecture that you run about the regenerative medicine. It is really one of the best that I have attended. And the other issue, I acknowledge the concern of Dr. Yasser that there are some abuse for the use of the regenerative medicine. And this abuse may be demonstrated in some of the data that give some bias or bad image about the regenerative medicine. Some said that it is not effective, but maybe due to not appropriate use, as you said. High leukocytic count has its indication, low leukocytic count has its indication. And I think this need to be more regulated. The people who implement these techniques need to be certified, need to have the knowledge how to use. And this, I think, the responsibility of every country to put the regulation for the certified physician who can implement this issue. And I think it's your role and the role of all the leaders in this field to guide the physician how to implement and how to use through the lectures and the webinars and the conference, and help them to attend this. I think this will be very important issue, and this is the role of all the leaders in this field. Thank you again for this great lecture, and I will be so happy to join all the team, inshallah, in the conference of the regenerative medicine. Thank you so much.
Thank you. Thank you so very much. There is no second opinion, doctor, that it should be very strictly and it should be very robustly regulated. Here in Pakistan, it took us more than 15 years But now we have regulatory bodies with us. We have Healthcare Commission and Pakistan Medical and Dental Council. It took me nearly 15 years to get regenerative medicine as a specialty into the Pakistan Medical and Dental Council. And I'm the first Pakistani to have on my license as regenerative medicine. And we are also working with our regulatory authorities, which are at provincial level, to develop a minimum service delivery standards, MSDS, and also the training protocols. As the seniors in this field, we have an extra responsibility to have more webinars, have more hands-on trainings, more lectures, more leaflets. That should be free of cost. Let it be Sadqa Jariya for all of us, right? So the more people know, they will improve. I know it will take some time, right? But quackery and abuse is there in every specialty, whether it's neurosurgery, it's spine surgery, it's all. I mean, there is use and misabuse. There is abuse and abuse, the use and abuse everywhere. But it will take time. But we as seniors and mentors to our juniors have to take this responsibility, and we should come up with more regular, simple lectures on specific topics. Just start with PRP, start with dextrose, prolotherapy, all those things, and give them confidence, right? So if you go through literature, like you said, lots of studies which are negative studies, when you go through their methodology, they never have mentioned that the number of platelets was more than 1.2 million. If it was less than, then it's not a PRP. How it can be a negative study? So that is what I speak on all the forums. I didn't include any negative study here, but when I talk with neurosurgeons or orthopedic surgeons, I take lots of negative studies, especially with their methodology, that this is not the method for preparing. So this is not the failure of regenerative medicine, it's the failure of that physician. So that is the...
Thank you, Dr. Anwar, again for the mesmerizing lecture. And I think nobody left and everybody enjoyed the lecture. And before we dive into the questions, I request Dr. Abdul Majid and Dr. Khalil to unmute themselves. And Dr. Abdul Majid is having some comment. Let's listen to him. And after that, I'm going to start the questions.
Thank you so much. Thank you. It was amazing and very good lecture, and we are very eager to meet Dr. Shahzad soon in Pakistan, because a lot of ideas. I'm concerned with the cellular part, as I started bone marrow transplantation 20 years ago in Baghdad, and I am a hematologist. I'm asking Dr. Shahzad about very small embryonic-like cells, vessel. How could you, because we started our work with this machine, which is MCS Plus in Baghdad, and we treated a lot of patients with MS, with the hematopoietic cells. I'm asking, how can you take these very small cells? Do you culture it, or you just take these peripherally stimulated cells? Thank you so much.
Right. So thank you so very much. I mean, Dr. Ahmadi, you are our mentor, one of the senior most person working in this specialty. So there are different types of kits which come with this machine. So you worked with hematopoietic stem cells, that is simply apheresis, and the other kit. This is specific. Yes. This is the specific kit that comes with the name of PBD-VSEL. So this kit separates three components. It components buffy coat, which has some hematopoietic cells, and the platelets and all those. Then it has platelet poor plasma, and then it has mononuclear cells, which does not have any hematopoietic cells. It's just the kit and its formation and centrifugation process which separates this mononuclear cells. And before separating, as I mentioned in the protocol, that we inject patients with filgrastim, that colony stimulate factor, for 4 consecutive days. that increases the number from 0.6 to 30% per microliter. So,
Yes.
so that's the protocol. We have cultured these cells to re-inject in the same patient, but it's just 3 to 4 hours procedure. And if we have to inject it in the knee, we further centrifuge it, and the lowermost part, which is the white part, we take these cells only, and the few RBCs, we take them out.
Thank you.
Thank you, sir. Thank you.
Thank you. And now let's start with the first question. Is from our friend Kareem. He's asking about the second or double spin.
Yes. So absolutely, there is no difference in doing a single spin or a double spin, right? The only thing we should be careful about is when we take out the PRP kit or the test tube out of the centrifuge, it has 3 layers. The lower part is RBCs. Then we have a dirty buffy coat, off-white creamy gel-like structure. And then we have the PPP or A2M part, right? Leukocyte poor PRP. So if it has all 3 parts, then it's the method of how you take out the product that is important, right? So after you take out, don't shake it, so it will mix the things, right? So the RPM should be, the most of the literature suggests is minimum RPM should be 1800, and it should not exceed 27 or 3000 maximum. We don't perform it at 4000 or 3600. For other conditions to isolate exosomes or all those things, we do go for 20,000 plus, but that is different protocol. But for PRP, you can have single spin, you can have double spin, whichever you are comfortable with. But there is no evidence published that injecting a double spin PRP produces more regeneration as compared to single spin. No, the difference is which part of the PRP you take. If you are injecting intra-articular, stay half centimeter above the buffy coat or the RBC. Take 2 to 3 ml, inject it, and then you can take the rest and inject peri-articular. If you are injecting into ligaments, muscles, for skin, all this, go deep, take it, push back, mobilize the buffy coat, and then you take it with, that would be leukocyte rich. So it's not important single spin, double spin, soft spin, hard spin. The important is where to use which part. I hope this helps.
Rabir, you have a question, or shall I continue? Okay, then I'll go for the second question from Dr. Iyad. He's asking about the recommended antibiotics that you use and which the preferred one, if yes, using the antibiotics, which one you prefer?
So we give only one prophylactic antibiotic, that is 750 milligram of Zinacef. Zinacef, ZINACEF. It contains, let me see what it contains.
Cefuroxime sodium. It's cefuroxime sodium.
Yes, cefuroxime. Yes. So it has both gram-negative,
Second generation.
So when I do any intra-articular or any other procedure, spine procedure, we give 750 mg. When I go intradiscal, we give 1.5 gram. And out of that, I take 0.1 ml from the same antibiotic. And before coming out of the disc, I give that 0.1 ml intradiscal antibiotic to avoid infection. So 750 mg of Zinacef, half an hour before the procedure for any peripheral or spine procedure. But if you are performing any intradiscal procedure, it is 1.5 gram. And out of that, 0.1 ml intradiscal. Thank you.
Doctor, I have a concern here, please. according to the surgical prophylaxis, when the company generated the NSAF for surgical prophylaxis, it recommended 1.5 gram at the time of the procedure, and then every 8 hours, 750 milligram to cover 24 hours. You give only one single shot, or you cover the 24 hours?
No, we give only one single shot. And trust me, in last more than 20 plus years, we have done hundreds of thousands of procedures. And alhamdulillah, not a single infection. Alhamdulillah.
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 السلام عليكم.
عليكم
وعليكم
السلام حبيبنا وسام، اخبارك؟
الحمد لله. Hello, my great professors, Dr. Shahzad. Really, I'm very happy with your fruitful presentation, and I have a simple question regarding our daily practice. Pain as a pain physicians, you know, like sacroiliac joint injection, root injection, whatever. This as a routine work of us. When we can expect the best, the time for best results after injection, PRP
Yeah.
in such cases.
Yes, one more thing is important. Usually this leukocyte poor PRP intra-articular, whether it is sacroiliac or knee or
This
hip or
meeting is being recorded.
right?
Yep.
Then what we have learned over so when we inject any intra-articular, what we started doing 3-4 years back is we add 2 milliliter 2 ml of tramadol, that is preservative free, with the PRP. So all those flare-ups which we used to have in patients after PRP injection, we don't get any flare-up. No flare-ups when we add PRP 2 ml to the product 3 or 4 or 5 ml we are injecting. So one is that. Regarding your basic question, after how long we see the improvements? So
Yes.
the symptomatic improvements are usually there within couple of weeks, right?
So expect improvement after 2-3 weeks.
Yes, around 2 weeks. And
Yep.
meanwhile, we put them on analgesics. Usually, my treatment of choice is tramadol plus Panadol, right? Or Panadine straight with paracetamol. So we can give any analgesic. We usually avoid giving NSAIDs, though there is some controversies. So for those 2 weeks, we can give analgesic cover, not NSAID cover. And if we add tramadol to our PRP, patient will start feeling immediately.
Yeah. So no rule for local anesthetics in such case. You don't mix PRP with the.
Yes, that is another very important point. Yes, very good question. Thank you for asking this. Right. So all local anesthetics, whatever they are, in whatever low quantity concentration, they are cytotoxic, and they inhibit the function of PRP and stem cells. So the safest way to do is to use lidocaine, right? In low concentration, 0.5% or even 0.125%, right? Inject it 3 to 5 minutes prior to giving your PRP or stem cell injections, because lidocaine has very excellent tissue absorption, very rapid tissue absorption. It absorbs there, its half-life is good, 30, 40, 45 minutes. And then after 5 minutes, you can give PRP. For knee, what we do here is we give 0.5% lidocaine, say 0.25 ml of lidocaine and 0.75 ml of normal saline, 1 cc intra-articular. Then I give the high molecular weight hyaluronic acid. that is given very slowly, right? So that we give in 3 to 5 minutes. It has its own added benefits, rather one for any knee or hip or even shoulder. It improves the viscosity. It creates surface tension. It gives a bouncing and cushioning effect. And then it also improves the life of PRP due to increased surface tension intra-articular. So for any knee joint, the protocol what we have evolved over the years is 1 ml of 0.25% lidocaine, then high molecular weight Synvisc. I mean, this is important to use high molecular weight because some low molecular weight are also being marketed all over the world. They are basically approved as skin fillers. They are not for joint supplementation. For joint supplementation, we need to have high molecular weight with their molecular size more than 2.5 or 3 million kilodalton. So we should be careful about that, right? So we should not use 0.5 million kilodalton size or loss. So it should be 2 million maximum, or it's better that we have 3 million or even bigger. That is single shot actually. Then that is given in 3 to 5 minutes. Then we give PRP. So by that time, numbing effect of lidocaine is there because of the
infiltration
blockage, yes, all that. But it itself is not there. It has been absorbed and washed off. So then its cytotoxicity is not there anymore. But please never ever mix it with the PRP.
Good. Okay. So I think it would be great if you provide us with these regimens in a table, right? Yeah.
Protocols, yes. Protocols.
For the protocols, yes.
Yes,
I
we
think
need the
it would be
protocols.
nice.
I would love if you come to our conference. We'll be having hands-on training workshop for regenerative protocols for everything.
Yes.
We'd love to have all of you here with us.
Inshallah, we love to be there.
Inshallah.
Right, Dr. Safa.
Inshallah.
Inshallah.
Of course, Dr. Shahzad, also Dr. Khalil and Dr. Abdel Majid have an open invitation to visit us in Menofia Governorate in middle of Egypt. It is a rural area, but beautiful and quiet. Dr. Yasser Rida and Dr. Yasser Taib are witnessed, and Dr. Abir Shif, of course. She
It's
is
my university.
great colleague.
I am proud.
Yes.
My university, I'm proud.
They are witnesses that she is quite governorate, and you will be happy.
Very beautiful. It's very beautiful.
Of course, firstly, we will be very happy and proud to have you there. And of course, you will be happy to spend some time with us in May, inshallah. I will send you invitation.
The best ftir mishaltet you will eat there, Dr. Shahzad. The best ftir mishaltet. I don't know how can translate.
Dr. Shahzad, you know fatir. This is a kind of patisserie, but Oriental food in Egypt, and we eat it with honey and some kind of cheese, which is called in Egypt old cheese.
You know which city is the food capital of the world?
What?
Which city is the food capital of the world?
Yeah.
I think India, China.
It's Lahore, right?
Lahore, yeah.
Yeah, Lahore.
So the best food in the world you will find in Lahore, and you will enjoy it.
Yeah,
right?
I have a round trip on Google about the street food in Lahore, and I have many pictures about it. And
yes, I saw your presentation. So, Dr. Safa, it will be an absolute honor and privilege to know all of you and to be friend and to be brother with all of you.
I think it's a new start of our period of.
I really feel humbled. Really feel humbled.
And so may I'm really have the feeling that I am between my family.
Yes, we all are a family. We all are
Oh,
family.
yes, yes. All of you have some ملامح from my brothers and Abir, of course, my young sister, and I feel the warmth of the family and the heart feeling of my family. Thank you for
Yes.
you all, for your great offer to support our society. Thank
I
you.
mean, you are the motive force for behind all these activities. Stay
Thank you.
blessed.
Thank you. It is my honor and pleasure.
And keep all your energies. Yes. May Allah bless.
Inshallah.
We have a fruitful message from Iyad Fadil. Iyad Fadil will be a moderator with us so soon. He said that Masr Dunya. Here in Egypt, we said that Dr. Shahzad, Dr. Khalil, of course, no, and Dr. Abdul Majid. Yes, sir, I'm sorry for interruption. I'm sorry. I'm sorry.
It's okay. It's okay. But
Mute my mic again. Mute me, Yasser, please.
okay, it's okay. We'll go back to questions again.
والله انت اجمل حاجه في الموضوع.
Yeah, we have lots of them, inshallah. But touching the point of the non-steroidal, Dr. Anwar, the point of the non-steroidal, do you recommend, as I know they recommend stopping the non-steroidal few days before the procedure. How long do you recommend that? For 2 weeks, for 1 week? Which is the best for the patient to stop the non-steroidal?
As far as PRP is concerned, if it again depends on what type of non-steroidal anti-inflammatories. If patient is on selective COX-2 inhibitor like etoricoxib, celecoxib, all those COX-2, there is no need to stop them. There is evidence I can share, published data on this, that whether you stop or you don't stop patient who are on COX-2 inhibitors, etoricoxib, celecoxib, or the related family, you don't need to stop it. But people who are on ibuprofen, who are on naproxen, all those other old steroids, right? NSAIDs. So that we need to stop at least for 5 days prior to giving PRP or stem cell treatment. So 5 days, if they are on conventional NSAIDs, if they are on COX-2 inhibitors, etoricoxib, celecoxib, there is no need to stop it.
Thank you.
And then they can start it after 2 weeks, after 2 weeks of the procedure.
So restarting after 2 weeks.
Yes. So if they are on NSAID, we can put them on tramadol and paracetamol combination, or phenidine straight and paracetamol combination, Nubrol, or the other combination. So they are equally effective. And if we have to give any anti-inflammatory, you can prescribe them COX-2 inhibitors.
Okay.
But better not to.
Because the antiplatelet action.
Yes.
Thank you, Dr. Anwar. We have a question also from our colleague Abdu. He's asking about the role of regenerative medicine in Guillain-Barré syndrome.
Guillain-Barré, right? It again, like any disease, it depends after how long the patient has presented, right? And for Guillain-Barré, it's not just the regenerative medicine. Along with it, a very robust physio-rehab protocol is important, right? So with regenerative, if the patient is still in the progressive stage, that is the best time to do it, right? Then the protocol, we do it, we find the level till what the damage is there. Say if still it's in the lumbar level, we'll approach through the foramen at L1 or L2 level, will do the neuromodulation of the dorsal root ganglia, and then we'll inject the PRP or the stem cell, whatever we need to do. In addition to this, we enter through the caudal space, hiatus, just below the hiatus, and we do burst modulation going up to the level of S2 with the RF cannula. We do the pulsed RF neuromodulation for 8 to 10 minutes or 12 minutes, whatever protocol one is following, one can do. And then before coming out, we can inject PRP or stem cells, and this, along with robust physiotherapy and rehab, can not only stop the progression, but also will improve the reversal of the symptoms and all those things. So it is definitely indicated, but in association with a very robust PMR program, physical medicine and rehab program.
Okay.
Assalamu alaikum. Can I ask a question, sir?
Yes, sir.
Sir, what about the pain strategy of post-herpetic herpetic neuralgia? Because sometimes it is so resistant that it cannot be even blocked, or sometimes multimodal analgesia cannot work for this, sir. What
So
strategies can you apply?
what sort of blocks you perform, Dr. Latif?
Sir, simple, this plain block, like which area it is affecting, sir? Like nerves are affecting this area.
Again, for this, we haven't done any work. I will go through the literature and you will find whether any, but generally for any post-herpetic neuralgia, what we do is we start with the rector spiny block at the affected level, dorsal, lower cervical, lower dorsal, lumbar level, right? That usually helps and helps for reasonable time.
Yes.
And then next step is dorsal or lower cervical selective nerve root block at the cervical level, and the transforaminal injection at the dorsal or lumbar level, right? And then the latest evidence is for more prolonged relief comes from pulsed RF neuromodulation of the dorsal root ganglia, again for 10 to 12 minutes, but this is level 2. First, we either erector spiny, selective nerve root, or the transforaminal injection. Trust me, 80 to 90% of patient will not come back to you for months, right? And if patient comes back early or patient does not respond to erector spiny block or the transforaminal injection, then the next step is again through the same approach, transforaminal, go and in the close proximity of the dorsal root ganglion. And the standard for that is you should have the sensory stimulation between 0.3 to 0.5 and motor at about 0.7 to 1 hertz. So that is where that makes, if you don't get your sensory at 0.3 and you get it around 0.71, or you get motor at 1.5 or above, the patient will again come back within few months. But if you get your sensory at 0.3 to 0.5 and motor 0.75 to 1, patient will not come back to you for years. Trust me, this makes lots of difference because this procedure is neuromodulation based. This is not injection based. So when you are in close proximity, you do a proper neuromodulation. Neuromodulation is to reverse the sensitization of dorsal root ganglia and first order neurons, which are the most important in peripheral and spinal cord stimulation, sensitization. So that is the most important one. So be in the vicinity of dorsal root ganglion, and gold standard for that is 0.3 for sensory and 0.75 for motor, right? Then 8 to 10 minutes, and then you can either give then give a non-particulate steroid. Don't ever use, please don't use particulate steroid in the neuraxial plane, whether in the foramen or interlaminar. For God's sake, because there are veins, there are other things, they can get thrombolized and you can get paralysis and even death of the patient. So please be careful. Don't use depot preparations in neuraxial plane. I hope that will help.
Thank you so much, sir. Thank you so much.
Thank you, Dr. Anwar. But before we pass this point, let's speak a little bit about the sympathetic block for the post-herpetic neuralgia. If the radio frequency is not available, is there any place for the sympathetic block? And are you using that, recommending that?
I mean, I haven't used any. And literally, I never needed to. I mean, even I haven't. Do you use in your practice sympathetic blocks for post-herpetic neuralgia?
No, I didn't choose. No.
We have cases used, and I have some connections in the US. They have some different, what they call it, difficult to treat. And I think I have connection with Dr. Candido, Kenneth Candido. He reported one case that is being treated after 3 blocks of the stellate ganglion. It was facial. This is just like V1 distribution. And he used stellate ganglion just like 1 week apart, 3 times. After that, the patient got more than 90% pain relief. I thought you had some experience in that, Dr. Anwar.
Very, very interesting. I will go through literature. I mean, this is really interesting.
Yeah.
The stellate for V1 distribution. Amazing.
Yeah. Yes. Yes.
Amazing. I mean, we usually go through the foramen ovale and we'll address V1.
Trigeminal. Yes, this is more easier. Yes, yes.
Yeah, but sometimes they don't respond to the block, the supratrochlear. That's why they go to the stellate. Anyhow, still we have some questions from our colleagues.
Yes, I have a comment.
Please,
About
please, Teresa.
about the select ganglion block. When you try everything and you can't get a result, you try to create something to get a result. Especially if the procedure is low profile side effect. And select ganglion block now used in everything. Even there is a case, many case reports, case series about loss of voice after COVID, and the patient improved. Post-traumatic stress syndrome, many things. So I have a patient here with trigeminal neuralgia, and I make him, he was mainly maxillary and mandibular. So I make an base of the skull, he don't get any relief, and typical trigeminal neuralgia. And I use an peripheral nerve. I'm injecting mental nerve, inferior alveolar and what's called infraorbital, and no result. And when I get frustrated because he's a medical doctor, I make him as sphenopalatine. This is some sort of crease. The patient improve a lot and don't have any pain now. I don't know how. Don't ask me. And even there is some case report about trigeminal neuralgia treated by greater occipital nerve block. Because when you get frustrated, you do something and it can help. Thank you.
A very good point, Dr. Yassereda. I mean, because with chronic pain, what happens is there is lots of crosstalk between autonomic and the nociceptive nervous system. And if we go through the cross-section of the trigeminal nerves, how many crosstalk it does with the upper cervical and all those things. So addressing trigeminal pain and post-COVID, all those things, and even long COVID, they have documented papers by stimulating it with pulsed RF radio frequency and giving PRP there for long COVID weakness and everything. So definitely there is lots of crosstalk between the CNS, peripheral nervous system, and the autonomic nervous system. So all get sensitized. And so one component, it settles down, it cools down. The other also get the positive feedback and they settle down. So there's lots of logic and lots of sense behind it. Thank you for your points.
Thank you. Dr. Khalil, you want to say something?
Yes, I want to thank Dr. Shahzad. He covered all the angle of the subject, but I hope we will have another lectures about specific about biomaterial, which is, I think, the core of the subject. We are doing in Baghdad, me and Dr. Abdul Majid, on spine intervertebral disc. I think we will share with Dr. Shahzad. I'm proud with him in workshop in Lahore. And thanks for Dr. Yasser, Dr. Abir, Dr. Safa for you. for this wonderful, amazing presentation from Dr. Shahzad. Thank you very much.
No,
But,
Honor is
we will present. I think we will continue communication with Dr. Shahzad, me and Dr. Abdul Majid, about the biomaterials, exosome, and thanks for logic question from Dr. Yasser and Abir for misunderstanding about the PRP, what they are doing. I think they need more knowledgement how to use. Thank you.
thank you, Dr. Khalil. Thank you very much.
Khalil, thank you.
I think we have also a new question from one of the colleagues. He is asking, do PRP can be effective in failed back surgery syndrome and injected multifidus muscle around fixing rods?
Yes, definitely it can be so helpful after failed back surgery syndrome. But again, the point is assessment of the patient. Because most of the patients who present to us after failed back surgery syndrome have sympathetic pain in their feet, numbness, coldness in calves, and they have more of canal stenosis rather than axial back pain, right? So for those patients, if we address just the multifidus and those paravertebral components, that will help partial. That is not taking all the picture into account. So for that, again, we need to have sympathetic blockade at lumbar sympathetic, L2, 3, 4, depending it's more on the feet or calf or whatever it is. That will help with improved blood flow, right? One thing. Second is going through the caudal, either do a high volume hydrodissection in the epidural space, and if you know how to perform a RAX procedure or epiduroplasty, that is the state of the art, the best over procedure we can do in failed back surgery syndrome. Because what happens after failed back or even chronic stenosis, that it's the ventral epidural space which has lots of adhesions, and especially the gutter where the just before the lateral recess, where the exiting root that enters into the foramen, that is where the most of the adhesions are, and that is where which causes pain and all those limitation in walking and standing. So with the RAX catheter, as it's a flexible catheter, spring catheter, we can dive into the exiting gutter, we can do adhesiolysis, we can inject then enzyme, further adhesiolysis, then high volume of steroid plus local. So this is the beautiful procedure. So if it's spinal stenosis, then doing multifidus, PRP, neuromodulation will not be of that much help. But if there is no stenosis and the patient has axial back pain, then definitely we need to give PRP. And if we have RF, we can do pulsed RF. Or even simply doing PRP and good stretching exercises will definitely help.
Really, Dr. Shahzad, the discussion with you opened a lot of opportunity and a lot of thinking about a lot of the clinical cases we are meeting in daily basis. I think we need a lot of webinars just for discussion of such cases and brainstorming, which will help us to put the best protocols for our cases. Really, thank you. Really, thank you.
Most welcome, sister.
Definitely. So, can I ask another question, or that's it, Dr. Anwar?
Yes.
Now
I mean, it's a weekend. It's a weekend. I had my coffee. I'm having then, water, so we can.
Yes, I bring mine also.
Yes, sir. I told you that you will spend the 3 hours, and you said no. maybe 1.5
We
hours.
thought it's just like 1.5 hours with
You will
breathing.
exceed the 3 hours. You will exceed your utmost level.
It's okay then. We will not abuse the we are speaking about the use and the abuse. We will not abuse Dr. Anwar, and we
Yeah.
just last question, and then you can finalize, Dr. Safa.
yeah.
Okay, the last question, Dr. Anwar, it's about the, we know that the main thing is about the degranulation with the growth factor and these things. And the question comes just like, how long is the half-life of these growth factors, and how do they survive? For example, the disc area is so
Hostile,
hypoxic.
yes, environment. This
So
hostile
hypoxic.
environment.
Yes. So please elaborate on that.
Yes. So the degranulation process usually starts during the centrifugation, right? Because of the friction and all those things. And then at our center and people who have been trained with us, they do the photobiomodulation. Photobiomodulation is using monochromatic light. That means one wavelength light of a specific color to stimulate mitochondrial function. We all know that mitochondria is the industrial unit, is the engine which runs, it converts AMP into ADP, ADP into ATP, and that is the energy molecule, right? So mitochondrial dysfunction is the key in all degenerative cascade, especially with osteoarthritis or disc degeneration, right? So once we keep the PRP after harvesting it in the light zone, we use LEDs. It is usually 660 to 680 nanometers, and yellow light, which is around 580 to 940, 600. So these two lights of LED, we put the PRP or the stem cells, whatever, before injecting for 15 minutes. So what photobiomodulation does is these photons of light, they bombard on the mitochondria. And what is happening in degenerative diseases, that there is increased levels of nitric oxide, NO. And this nitric oxide forms a bond between cytochrome C and nitric oxide. Cytochrome C is a photoreceptor and is the key molecule in electric transport chain. Allah has been so kind that so when we bombard light on mitochondria, the first thing it does, it dissociates the bond between cytochrome C oxidase and nitric oxide. Nitric oxide comes extracellular, where it is the most important, and it regulates the pH and everything. Once cytochrome C is rendered free of the nitric oxide, the mitochondria starts producing ATP. So a regenerative cascade starts. So photobiomodulation of PRP or any degenerative tissue is very, very important. There's lots of data on internet. You can find level 1 evidence of photobiomodulation using LED or laser lights to improve pain, dysfunction, all those things. So during these 15 minutes, further degranulation happens, and there is more activation of the mitochondrial dysfunction. So then the point is, the question was how long? So it should not be more than 45 minutes to 1 hour outside the body. From taking sample and re-injecting it into the spine or joint or muscle or ligament, it should be ideally between 30 to 45 minutes. So it should not go beyond 1 hour. And if it goes beyond 2 hours, it is just like injecting a placebo. And regarding the hostile environment in the disc, it is not that hostile for the PRP because they are just the growth factors, and they are attracting mesenchymal cells and releasing cytokines. So it is that hostile environment is more dangerous for the stem cells. For that, what we are doing is we are injecting just 0.25 to 3 ml combination of 50% PRP, 50% exosomes. So that will help improve the hostile environment, and then we inject the stem cells. So that hostile environment is neutralized by exosomes and PRP, and stem cell will function better. So with the intradiscal injections, PRP is not the worry. The worry is stem cell, but for that, if we have PRP and exosome, just 0.25 to 0.3 ml, and then 0.5 to 1 ml of stem cell. That will give them a good life.
Thank you very much. Really did not have enough questions, but that's enough for today. I will just.
I think you forget a question from Hannah. She asked about the use of regenerative medicine in ankylosing spondylitis. I think there's a question like that.
This is a beautiful and very, very important question.
Always I come with the beautiful, even for people and for the flowers.
Yeah. Yes, as I already said, you are the basic energy and the force behind all this. May Allah bless you.
Thank you.
So now coming to the question.
Dr. Shahzad, before to go, sorry, because we give Dr. Safa the name, the mitochondria, the house power of the cell.
Yes.
Give him their name.
Yes, he is the house power. Yes, powerhouse.
Really, Dr. Shahzad, it is very memorable webinar, and I really I'm amused. I think this topic is away from my thinking, away from pathway as an obstetric anesthesiologist. But really, I every minute in the webinar I'm interested, and I'm fully awake with you with your huge knowledge. Thank you for your effort. Thank you.
And you know, we are 3 hours ahead of Cairo. It's already past midnight here.
Thank you.
Right. So coming to ankylosing spondylitis. So it is an autoimmune disease. The best part about regenerative modality, whether it's simple prolotherapy, giving different concentrations of dextrose, or using different forms of platelet-rich plasma, leukocyte-rich or leukocyte-poor, or stem cells, the first thing it does is the immune modulation, especially the mesenchymal stem cells. So what PRP does, after we give PRP injections, it causes the relief of cytokines, which give an SOS signal to mesenchymal stem cells, and lots of numbers of mesenchymal stem cells are attracted to that area. So for this doctor who asked this question, the protocol should be, you can use ultrasound or you can use fluoro guidance, and you can give PRP or whatever you can give. You can use leukocyte-rich, you can use all the PPP, and you can give in the perivertebral muscles, along the facet joints. So the basic is what's happening in ankylosing spondylitis is it's the autoimmune response exaggerated that is damaging the spine tissue and the joints and everything. Then we get the bamboo spine and loss of movement and everything. So this, first of all, it will not only improve the pain and disability, it also has disease modifying role. So very, very important, not only for ankylosing spondylitis, also for rheumatoid arthritis. So lots of avenues for regenerative modalities.
Thank you.
Great.
Yes, sir. You have any of the floor question? Yes, sir.
I think no, I passed all the questions from me and from the floor. I will have enough now.
Yes.
Amazing.
Of course, the WhatsApp group of January 6th will remain to, inshallah, January 6, 2025. It
Inshallah.
will be open, inshallah, to celebrate each other by our brotherhood and my sister, of course, Abir, and to celebrate every day that
Dr. Safa,
we
just
lastly
one.
meet each other.
Yes, just one point. I mean, today's lecture was just to give an overall view of the regenerative medicine.
Yeah.
Me with Dr. Khalil Juma, Dr. Abdul Majid Alwan Hamani, we can devise a structured program starting from the very basics, including both biomaterials, scaffold, exosome, cellular, acellular, and then it could be one every 2 months or something like it.
Very
so
nice.
that,
Very
yes.
nice. So
we can develop a structured program, and then we can have hands-on training either here in my part of the world or in Egypt or in UAE, anywhere, and our services are there absolutely free of financial, I mean, we'll come at our own ticket, we'll stay at our own expense, and we'll teach.
Thank you. So, Dr. Shahzad, it is my open invitation for you and Dr. Khalil and Dr. Abdul Majid, and of course my dearest colleague Yasser Rida, Yasser Hassan, and of course Abir and Dr. And all of the team of our team to attend our conference, and we may arrange or prepare, if you allow me, Dr. Shahzad, to have a pre-conference workshop about the role of new era of medicine, the role of the regenerative medicine. And I will prepare with you to have such a great event for the first time in Egypt.
Dr. Safa, I think we can prepare patient also.
Yes, I will too. But
I can.
The secret. Don't mention for Dr. Shahzad or Dr. Khalil. Or
I mean, I can arrange with Sadiq and Wissam, and we can prepare patient for this.
Please, Abir, don't mention. It is a deep secret between me and you. Don't mention it now.
خلاص. We will prepare it, Dr. Safa. We will prepare.
Dr. Yasser, it is still a secret.
Dr. Shahzad, it's just online. It's just online secret.
Open secret.
Yeah, open secret. I'm so happy and I'm so glad to meet such a great person like you. You are great achievers. You support me today and make my day. This is one of my best webinars, and I am so honored and pleased to have you. Till we meet again next Saturday, all my praise for you to have joyful and all the happiness, all of your time. And I love that the dua, ربنا يكبر خاطركم. ياسر الطيب can translate ربنا يكبر خاطركم for Dr. Shahzad. I don't know what it means. But I love it.
Make you happy.
Allah, Dr. Shahzad, Allah blesses you for your support to this society and the generous knowledge that you offer to all of us, and you will offer to our postgraduates in all over, in not only in Egypt but all over the world, inshallah. Really, thank you.
Of course, Dr. Khalil and Dr. Abdul Majid عارفين يكبر خاطركم, ربنا يكبر خاطركم.
Thank you very much.
Can you listen to me? Hello?
Yes, we are listening, Professor.
My name is Dr. Miazar. I am basically professor of orthopedic surgery and one of the colleague of Dr. Shahzad. It seems to be, I don't know how should I express my feeling, but I'm very, very, very much impressed with Dr. Shahzad. It looks like that he was delivering a lecture on the basis of an orthopedic surgeon. You guys asked most of the questions of an orthopedic related specialty, and he answered very nicely. Very impressed, very proud of him. May God bless him. He is a basic a man behind this whole shows, the regenerative medicines, and he is in the habit of creating new things, new eras. First, he is basically a pioneer in this pain medicines in our country. He started delivering, started promoting, and Alhamdulillah, he is very much successful. And now I'm really very happy to have a great interest of all of you in this field. We all respect you. You are our brothers, our sisters, and I'm impressed with your level of dedications. That makes you sound. That makes the medical people's stronger sounds if you have an interest, deep interest. And it was really amazing. I'm sitting quietly since the opening of this lectures. It was excellent. And I also thank on behalf of me and Dr. Shahzad. Shahzad is very junior to me in age, but he is senior to me in this field. And I think I always says I am not a professor, but I am a student of Shahzad. He is a wonderful guy. He's a wonderful guy. And we here work as a team. As a team, we are all now FIPP. We have done all the FIPP, and we are trainer, teachers, moderators of the pain medicine here. And inshallah, we will start working on this regenerative medicine with your support, with your help, and we will keep on reciprocating all the things. I thank you all. Thanks all of you on behalf of SIPM and on behalf of Pakistan chapter. That thank you very much, my dear friends, my dear sweet loving sisters, and thank you very much. We all respect you. We all love you. We are all a family. Thank you very much.
Thank you, Dr. Mayan. Thank
Thank
you
you,
for your
Professor.
valuable contribution. Thank you. You are welcome all the time.
Thank
Please,
you,
every one of
Professor,
us
for the
now
kind words.
will open his camera, and we will have a photo. All of us. Wissam is here. Anyone wanted to open his camera? You are all welcome to have a photo.
I take photo.
Yeah, we will get more photo. Yeah, anyone wanted to open his camera? It's okay. Welcome. You are welcome.
Thank you.
This will be a memorial photo for this great gathering.
I cannot open my camera because it's 12:30 here, so all are sleeping. That's why.
Yeah. I'm sorry.
But
I
you
sent
will-
the photo.
You
I
all
sent-
will
Okay.
live. You
Thank
all
you.
will live in our heart. Camera is not important. You all will live in our heart.
Thank
The
you.
second time you must buy a new camera, please, or a new phone. You are all welcome.
Thank you.
So thank you so very much. Thank you, everyone.
Good
Thank
night.
you.
Good night for
Thank
you
you.
all.
Thank
May
you.
Allah
Thank you for you
bless
all. Thank you.
Thank you.
Really, I will miss you. Really, if this is my last webinar, it is more than enough for me to have such a great gathering and this great bunch of scientists.
Don't say
and-
it. You have millions of more webinars to come.
Inshallah.
Inshallah.
Thank you. Thank you.
Thank you.
Thank you.
Stay
Salam
blessed.
alaikum.
Yes.
Wish you
Wa alaikum
good night.
assalam.
Assalamu alaikum.
God bless
Assalamu
all of
alaikum.
you.
Thank
God
you.
bless all of you. God bless
Thank
all
you.
of you. Love you all.
Thank you.
Thank you.
Thank you. Assalamu alaikum. Assalamu alaikum.
الله يحفظكم. الله يحفظكم.
الله يحفظكم ويبارك فيكم يا رب. الله يبارك فيكم.